Myself, Dr. Aguila, Professor, Department of Periodontology, Chitna Dental College and Research Institute. The topic for today's discussion is on aggressive periodontitis. So by the end of this discussion, you would be able to define aggressive periodontitis, differentiate between different forms of periodontitis, identify the risk factors of the disease, identify the clinical and radiographic features of the condition, classify the types of aggressive periodontitis. So to introduce periodontitis, previously called as Rick's disease, the aggressive periodontitis previously was called as juvenile periodontitis or early onset periodontitis. So moving on to the history, the other names for aggressive periodontitis includes diffuse atrophy of the alveolar bone, deep cementopathia given by Gottlieb in the year 1923 and 1928, periodontitis marginalis progressiva, Vanenmacher in the year 1938, and it is also called as periodontosis given by Thoma, Goldman and Orban in 1940, 42, 47, juvenile periodontitis by Chaput, Butler in the year 1967, 1969, early onset periodontitis in the year 1989 by American Academy of Periodontology and 1993 European classification. So in the World Workshop in Periodontics 1999 classification, it was proposed as aggressive periodontitis. In the year 1971, Baer has given the definition as disease of periodontium occurring in an otherwise healthy adolescent, which is characterized by rapid loss of alveolar bone about more than one tooth of the permanent dentition. The amount of destruction is not commensurate with the amount of local irritants. Linde has proposed the definition as aggressive periodontitis comprises a group of rare, often severe, rapidly progressing form of periodontitis, often characterized by an early age of clinical manifestation and a distinct tendency for cases to aggregate in the families. So what are the features? It includes primary and secondary features. The primary features includes, which is non-contributory medical history, there is rapid attachment loss and bone destruction and familial aggregation of the cases. So you can see in this X-ray or the OPG, there is rapid bone loss at the baseline and there is some improvement after 9 months. Without treatment, there is no improvement. There is rapid progression of the bone loss. The secondary features include microbial deposits which are inconsistent with the severity. The aggregative bacter Actinomycetum comitans and the Porphyromonas gingivalis are the predominant organisms. There is phagocyte abnormalities, hyperresponse macrophage phenotype and progression may be self-arresting. The microbial deposits are inconsistent with the severity. As you can see in the clinical picture, there is severe soft tissue loss with less amount of inflammation and accumulation of the dental plaque. What are the subclassification? It is classified further as localized aggressive periodontitis and generalized aggressive periodontitis proposed by Tonti and Mombelli in the year 1990 and Lang et al. In the year 1999. So localized aggressive periodontitis is onset is around circumpubertal. Usually the first molars and incisors are affected, at least 2 permanent teeth and not more than 2 teeth affected more than incisors and molars. There is robust serum antibody response. In generalized aggressive, the age group that is affected is generally below 30 years of age. Patient affected may however be little older. There is generalized interproximal bone loss. At least 3 permanent teeth is affected other than first molars and incisors. Poor antibody response and it is episodic in nature. The localized aggressive periodontitis, the rate of bone loss is 3 to 4 times more than that of the chronic periodontitis. There is distolabial migration of the maxillary incisors with diastema formation and increasing mobility of maxillary and mandibular incisors and first molars. And there is sensitivity of the root that is denuded due to thermal and tactile stimuli. There is deep, dull, radiating pain during mastication. The periodontal abscess and there is also lymph node enlargement. Sometimes the progression of attachment and the bone loss is self-arresting. In the case of localized aggressive periodontitis, the radiographic findings, you can expect vertical loss of alveolar bone around the first molars and incisors, which begins around puberty in otherwise healthy teenagers. There is arc-shaped loss of alveolar bone extending from distal of second premolar to mesial of the second molar. Moving on to generalized aggressive, generalized interproximal attachment loss with 3 permanent molars other than first molar and incisors. 2 gingival tissue responses are expected. Severe acute inflamed ulcerative tissue destructive stage of the disease. The gingiva is pink, free of inflammation, stippling, deep pocket on probing. The diagnosis, how to differentiate between chronic and aggressive periodontitis is based On the radiographic findings also, in the case of localized aggressive, you can see that there is vertical loss of bone, that is an arc-shaped bone loss. Can you see from the second molar, the distal surface of the second premolar to the mesial surface of the second molar. In generalized aggressive, you can see that there is, as you can see in the radiograph, there is generalized severe bone loss. So the microbial diagnosis is bacterial culturing, DNA probes can be utilized, and enzymatic analysis. The immunological diagnosis is based on the crevicular fluid, prostaglandin ED, specific IgG2 antibodies to Aggregatibacter actinomycetum comitans, and genetic diagnosis is based on the family tree. So what is the prevalence and distribution? Localized aggressive periodontitis less than 1% of adolescent population. Generalized aggressive periodontitis is 0.13%. The blacks are at a higher risk when compared to the whites. Males are at a higher risk of generalized aggressive periodontitis than the female. So what are the etiology? Etiology is, as I said previously, bacterial, immunological, genetic and environmental factors. So microbial factors, as you know that localized aggressive periodontitis is normal, whereas in the case of generalized aggressive, it is also associated with genetic modifying factors and the modifying environmental factors. So the risk factors are associated with the microbial factors: Aggregatibacter actinomycetum comitans, Porphyromonas gingivalis, P. intermedia Fusobacterium nucleatum, Campylobacter rectus and Treponema denticola. Bacterial invasion of connective tissue is also seen. The immunological responses, the human leukocyte antigen A9, B15 are associated. Porphyromonas, PMN and the monocyte functional defects are also expected. The treatment regimen is poor prognosis tooth are extracted, especially the first molars, severe bone loss, standard periodontal therapy, antibiotic treatment, microbial testing and antibiotic sensitivity, followed by surgical procedures with regeneration, individually tailored followed SPT program. So what is the suggested antibiotic regimen? Chlorhexidine locally administered, tetracycline locally administered in the form of local drug delivery, or you can give systemic administration for 14 days, doxycycline 100 mg for 14 days, metronidazole 200 mg for 10 days, or combination of metronidazole and amoxicillin for 2 weeks. Other regenerative techniques includes root surface biomodification, growth factor delivery, enamel matrix derivative, that is endogame, and platelet-rich plasma. So to summarize, we can tell that the etiology is multifactorial. However, aggressive periodontitis early diagnosis is essential and prognosis is better with early detection and appropriate management. Thank you.